Okay, so most of you know that we've been in the midst of an opioid overdose crisis in the United States for nearly 2 decades. And you may be less familiar with the opioid overdose crisis as a global public health concern. So this graph shows opioid-related deaths per 100,000 by country. And bars are colored based on the prevalence, green being low, yellow being kind of in the middle, and red being high rates of overdose deaths. So you can see it varies across countries. And the United States has the highest rate of opioid overdose deaths, this last bar here, significantly higher than any other country. And within the United States, life expectancy is decreasing, at least partially due to opioid-related deaths. So these figures show age-specific mortality rates from 1999 to 2017. And you can see each graph is broken down by age group. You can see the age group across the top. The age-specific mortality is on the y-axis and the year on the x-axis. And I just want to point out one of these lines. I know there's many lines, but the black line is drug poisoning. And you can see in 3 of the 4 different age groups, the mortality rates have increased significantly. And notably from 1999 to 2017, women demonstrated a more rapid decrease in life expectancy and increase in drug-related deaths than men. Evidence-based treatments for opioid use disorder include medications, behavioral therapies, and other care coordination services and harm reduction strategies. And of these different treatment options, we know that medications are the most efficacious. In the United States, the primary medications for opioid use disorder include buprenorphine and methadone. However, in other countries like the Netherlands and Switzerland, there are additional medication treatment options such as heroin-assisted treatment and slow-release oral morphine. And we know that treatment works, but there are disparities in access to and engagement in treatment. So this is a figure of global coverage of medication for opioid use disorder among people who inject drugs. And it's also color coded. So the lightest purple is just where there is medication provided, but there's no estimate. And then as the color gets darker, it's more recipients of medication for opioid use disorder per 100 people. And the gray areas, the darker gray, show where there's no MOUD offered. And then this lightest gray, there are no reports of people using injection drugs. And you can see that here, the United States is really on the lower end of access, with only 0 to 100 people receiving medication for opioid use disorder per 100 people who use injection drugs. In addition to disparities in access based on location, there are gender disparities in treatment access, with women being less likely to access treatment, largely due to increased barriers like pregnancy, intimate partner violence, and stigma. Women are also more likely to experience more psychosocial vulnerabilities when they enter treatment, such as higher rates of mental health comorbidities, unemployment, and childcare responsibilities. And this brings me to the social determinants of health. So social determinants of health are the conditions and the conditions in the environment where people are born, live, learn, work, play, and age. And they have a major impact on our health and functioning and quality of life. And this figure shows the Healthy People 2030 Social Determinants of Health framework. And it highlights 5 different determinants, which you can see here, the 5 categories. And while research has identified differences between men and women in social determinants of health at treatment entry, like I mentioned before, those barriers, less is known about the relationship between social determinants of health and opioid use disorder treatment outcomes by gender. So assessing how factors across each of these determinants impact opioid use disorder treatment outcomes by gender is critical to improving gender-informed care. So for the current study, this is the publication here. It aimed to explore social correlates of opioid use disorder treatment outcomes from each of the 5 determinants in the Healthy People 2030 framework, separately for men and women receiving buprenorphine for opioid use disorder. And so this was a secondary data analysis from the Motivate survey study. It was a cross-sectional survey of reproductive and sexual health needs with the prospective medical record review. For this study, we included participants who were receiving buprenorphine for opioid use disorder at Motivate. And none of the participants in the parent study identified as a gender minority. So our analyses for this study and all the other Motivate survey studies are limited to assist gender conceptualization of gender identity. Okay, so for the specific variables, we had self-reported gender, sex, race, ethnicity, and age. And then we calculated length of current treatment episode at the time of the survey. And then the survey also assessed these different areas of the social determinants of health. So for education, we had the level of education, economic stability, we looked at employment status. For the neighborhood and built environment, we used one item that asked, did you miss appointments, limit grocery shopping, and/or stay with others because you felt it was unsafe to leave or return to the neighborhood where you lived? And then for healthcare access, we looked at a transportation variable. And for social and community context, we used a social support measure that calculated a mean score ranging from 1 to 5, with higher scores indicating more social support. All right, and for opioid use disorder treatment outcomes, we assessed those using the medical record review over 7 4-week treatment periods, or approximately 6 months. We looked at treatment retention, which was defined as remaining in treatment 6 months after survey completion. Substance use recurrence, which was characterized as the number of treatment periods with a positive urine drug test for a non-prescribed substance. And lastly, buprenorphine continuation, which was operationalized as the number of treatment periods with a positive urine drug test for buprenorphine. Okay, and so all of our analyses for this study were gender stratified. We conducted both univariate and multivariable analyses. For our multivariable models, they included variables based on this Healthy People 2030 Social Determinants of Health framework that I reviewed on the previous slide. And we also controlled for length of treatment episode and age. So for these analyses, the participants were 142 men and women. About half were women, and they were middle-aged. Most identified as non-Latinx Black or non-Latinx White. Most participants had been in treatment for at least 1 year on average at the time of the survey. And women were significantly younger than the men in the study. So here's the table for our results for the social determinants of health, the social factors in each of those 5 domains. So you can see the domains are listed here, with each of the variables, and then they're split up by men and women, and then we have the p-value here. So for the social determinants of health domains, women were significantly less likely to be employed and more likely to live in a safe neighborhood than men, as you can see highlighted here. And education, transportation, and social support did not differ significantly by gender. And for our opioid use disorder treatment outcomes, men were more likely than women to have a substance use recurrence during the follow-up period. But treatment retention and buprenorphine continuation did not differ by gender. So here are the results for the multivariable logistic regression for treatment retention. Here are the variables that were included in the model, and then again separated by men and women with the odds ratio and p-values for each here. And in the multivariable models, when controlling for age and length of current treatment episode, women who were employed and had at least a high school education were less likely to remain in treatment through the follow-up period. And this was only true for women, it wasn't true for men. And none of the variables included in our other two models for men or women were significantly associated with substance use recurrence or buprenorphine continuation. So I'm not going to show those results here just for time's sake. So one of the most unexpected findings was that women who were employed and had a higher level of education were less likely to remain in treatment. Although employment is typically upheld as a positive indicator of addiction recovery progress, the relationship between employment and substance use disorder treatment is complex, and it does vary by treatment modality. So specifically within opioid use disorder treatment settings in both the United States and Canada, employment has been negatively associated with continuing MOUD. And this is likely due to barriers such as loss of public insurance, limited clinic hours, and stigma in the workplace around medication for opioid use disorder. And our results suggest that this association is more prominent for women than men. And one possible explanation for this gender difference is that social norms are less accepting of opioid use disorder among women than men, leading to increased stigma and discrimination for women receiving MOUD. Alternatively, for many people in opioid use disorder treatment, tapering off medication is an important goal. So vocational stability resulting in treatment discontinuation may reflect a positive recovery outcome rather than a treatment failure. So it's just important to keep in mind kind of both sides of this finding as we explore more. So our findings begin to show how social factors can impact opioid use disorder treatment trajectories differently by gender, and suggest that we need to study these associations in larger multi-centered samples. Because this was a secondary analysis, we were limited to the variables included in the study. The non-significant findings for men may have been due to lack of gender-related social variables in the analyses. So for example, based on the work of Nelson and colleagues, level of work strain, a gender-related social variable, may be more influential on men's treatment outcomes than solely employment. Similarly, we were unable to include more community-level social determinants of health, such as percent living below the poverty line in a given area. So we were only able to focus on those individual factors. So future opioid use disorder treatment research should incorporate both measures of gender-specific social factors as well as community-level structural variables. And before I wrap up, I just want to bring us back to that kind of global context. This is a figure that combines a little bit the two figures that I showed you at the beginning of the presentation. And it shows treatment and harm reduction coverage by country as measured by average number of MOUD recipients and average number of needle syringe distribution per 100 people with who inject drugs. So the needle exchange is on the y-axis. The medication for opioid use disorder is on the x-axis. And then the size of the bubbles indicates overdose rate per 100,000, and they're color coded with the high overdose rates being blue, moderate overdose rates being orange, and low overdose rates being gray. And so when comparing the rates of treatment and harm reduction coverage among a range of different countries with varying overdose rates, countries with low overdose rates tend to have high coverage and accessibility, like you can see up here. So the Netherlands is a good example that has both high harm reduction and treatment coverage and very low overdose rates. And then some of these others have higher of treatment or higher of harm reduction and low rates, which is the opposite of the United States, which is down here in this corner, showing kind of low harm reduction coverage, low treatment coverage, and the highest overdose rates. So I think for us, it's important to explore alternative opioid use disorder treatment models in other countries that are showing these high rates of treatment and low rates of overdose, because you might hypothesize that these countries are doing a much better job addressing and mitigating the social barriers to care. So in conclusion, and just say that implementing patient-centered care strategies can help facilitate opioid use disorder treatment continuation, particularly among women. And this might look like flexible clinic hours, so having clinic hours before or after work, or providing childcare. Gender-related social factors should be considered in opioid use disorder treatment research and clinical practice, as I mentioned before. And it's also important for us to explore these alternative models of opioid use disorder treatment globally. All right, thank you all for listening. So I'll open it up for questions and discussion. And I'm gonna stop sharing, but I can share again if anyone has questions about a specific slide.
Awesome, Beth, thank you. It's exciting to see that paper come alive in the oral presentation that we came out with. So I'll, like Annabeth said, open up for any points of clarity, and just remembering that Annabeth, this is she's taking feedback, but she will be presenting this at a conference. And just remind us, Annabeth, I think a lot of my notes that I'll tell you at a different time, we don't have to go over today, I think had to do with like tailoring it for the audience, just because we all know a lot about opioid use disorder, opioid disorder treatments and all that. Can you remind us what is the audience of this conference, and maybe that will help people give some feedback too?
Yes, that's a good point. So it is focused on women's mental health. It's not necessarily focused on addiction. So there is like addiction and substance use disorder is a piece of it, but it's not like a lot of addiction researchers are going. Probably lots of psychologists and people who work with women, but not necessarily in the addiction field.
And is it mainly researchers or clinicians or both?
I've never been, so I'm not actually sure, but I think mainly researchers.
Okay, that's helpful. Yeah. Okay, I'll open it up for feedback that people have with that in mind.
Hi, Annabeth. Great presentation. I just had a question about you summarizing the end how the is lacking in some of the social structures that can support harm reduction. So I guess someone would ask, I know you're also suggesting that we should countries such as Netherlands that have better assuming social structures. So what are those social structures that you're suggesting that aren't quite being practiced yet in the US?
Yeah, that's a good question. I think some of them are like what I mentioned at the end, just more patient-centered strategies to help with those individual level social determinants of health. So providing transportation, like public transportation, other countries do a much better job than us at that. Providing childcare, having those flexible clinic hours. But I also think there are like country level laws and policies that we don't necessarily have in the United States it's against the law to provide heroin assisted treatment and things like that. So I think there are some things that we can maybe learn and implement, and other things that are not necessarily things that we could do here, but we might can learn some piece of it that would be applicable. Does that answer your question?
Yes, thanks.
Okay.
I am not an expert in the kind of the global, presenting it for an audience like you were saying. I'm not an expert in that, but I thought you did a good job at that. I know that was one thing that you were concerned about, was making sure that it's applicable to an international audience. I think you did a good job about kind of spickling that in, not just at the beginning or the end as an afterthought, but it did seem like you wove it in. And I really like that figure on the last slide. I've never seen that before. It's kind of disturbing.
I mean, yeah.
Oh my gosh.
Mhm.
But I thought you did a good job. But if anyone has any experience working, presenting with an international audience, I know Annabeth is in particular looking for that type of feedback.
I just had a general question, and this is because I do insurance research, but how do you think like the uniquely American insurance system influences your outcomes compared to in a Netherlands or other global systems?
Yeah, that's a really good question. I think particularly with the finding that employment was associated with discontinuation of treatment, I think that could potentially have something to do with the loss of public health insurance. And so for other places where they don't have to worry about that, where there's universal health care, I think that you would see potentially different findings if unemployment might not be impacting our outcomes as much if they just have insurance regardless, or have free healthcare regardless.
Yeah, that makes a lot of sense, especially considering how big of a payer Medicaid is for, or in Medicare for these services.
Yeah, I do need to look though, because I thought that Canada had universal health care, and some of the other research, like papers, the limited stuff that's out there about this was from Canada, and the employment was also negatively associated with treatment continuation there. So it could be that that's more of the like vocational stability is a treatment success kind of thing. So I think there's a lot of nuance, and it's worth looking at in other samples.
Yes, as someone who has presented in like global conferences, and like I have experience working in low and middle income country settings, I think it's challenging because like that first chart that you showed, all of the countries were like high income countries, right? I didn't see many low and middle income settings. And it's hard because it's hard to know if that's like truly reflective of like low rates in low and middle income countries, or if it's just like not as robust data collection structures, and we just like don't know the landscape. So I think that's just like important to remember, and like maybe worth making a comment about at the beginning and at the end. And also yeah, that's just like my 2 cents there.
Yeah, that's really helpful, because the one I hadn't thought about that for that figure. The other figure that like maps of more like the globe of, it shows more of, I think it was most of Africa. It says that it doesn't even like have medication, and you're right, I don't know if that's because of lack of research or it's actually not provided, or maybe a mix. So do you think that's important to keep in mind? Thank you.
I was also wondering if you think after your last slide that says, especially European countries, since the conference is in Europe, maybe if you want to see the social determinants of health or the factors that they are specifically working on has shown improvement, like you mentioned, transportation and things, insurance, maybe you can add a slide on how these countries are doing things differently. And that is the reason. So maybe if somebody's in the audience from that country can give you feedback on what we are doing that is working, and maybe others can also probably join in to see how at a global stage you can change things. But Just wondering if that helps.
Yeah, that's a good point. I think it would address kind of both of the other questions that came up. It would help address those. So I think
Yeah,
that's
so just kind of brings together like a big picture since you are doing a global conference. So yeah.
Mhm.
Most of my comments, Annabeth, and I can talk to you about these offline, have to do with just from my experiences giving talks about addiction
Mhm.
to audiences who don't work in that space every day. And so a lot of my suggestions will just be taking advantage of reminding people throughout the presentation, like buprenorphine is a medication that we use to treat opioid use disorder.
Mhm.
It is given in a clinic-based setting where patients have to come in every month for a prescription. Just kind of those basics those what are considered basics to us. And so a little bit of most of my comments are about just kind of putting that foundational knowledge about what we do in the treatment setting, and especially linking it back to clinical care. Because I think if this is a research heavy conference, people are going to really like your presentation because it's very clinical. And so the people who are like itching for like the clinical and social stuff are gonna be like, yes, I'm so excited for this presentation. So linking it back to how this was a study in a clinical setting, which is a small sample size, but that's what makes it unique. So focusing on that clinical setting will be good. And then don't be afraid to repeat yourself is something I've learned many times which seems kind of, you feel like you're repeating yourself over and over again, but just repeating like what buprenorphine is. Treatment retention is considered a classic outcome for addiction research, those types of things, and linking it back to your study design a little bit more to refresh people's minds about what the study was and why you chose your outcomes would be a good idea.
Okay, yeah, that's a helpful reminder. Thank you.
Any other feedback or comments or questions that people have for Annabeth?
Hi, Annabeth. It's Margie. I have a quick, first of all, I found this so interesting. I just want to say I love that you are going back that huge step and going, okay, let's look at all the social determinants of health in relationship to the gender. I just think that's incredible. I'm just curious if there was any, when you talked about the women who particularly were employed and a little higher education, that tended to be the ones that were not staying in the treatment. If there's any idea of what types of jobs, or even distinguishing between a blue collar and a white, because a lot of the blue collar jobs, unfortunately, there's not any flexibility for people. And I have to say some of those jobs are also doing weekends and things like that. But I'm just saying, like, the flexibility can be a huge piece. And then the other part I wondered about was there anything in there about whether or not somebody had children at home in their care versus not? Because there's a lot to juggle, once you add work. I'm just curious.
Yeah, those are really good questions and a really good point. We did not get at the level of what job people had or what their employment was, who they were employed by, I guess. It was just like employed or not, or, homemaker, student, kind of those things. But I think that's really important to keep in mind moving forward with social determinants of health, and getting that more granular data. And we did have information about children in the home. I think we didn't include it in this because we were trying to stick to that like social, the Healthy People 2030 framework, and they didn't really have a great spot for that. As we were trying to make things fit with that. Because this study was mostly at Motivate, the sample was a little bit older, and so it wasn't the like kind of OB Motivate population that we see. So I think fewer people had children at home, but I don't know for sure the impact that would have had in this. It could have still had an impact.
Yeah. Interesting. Yeah, my mind, I go through all these different questions as I watch this. I love what you're doing.
Thank you.
Thank you.
Any last feedback or questions for Annabeth? Okay, Annabeth, I think you're off the hook.
All right. Thanks, y'all.
Yeah, thank you for presenting. It's exciting research, and I'm excited you get to share it with such a big audience soon, and you get to go on a fun trip. So that's great. Well, lovely. I'll send you the feedback notes that I took from everyone, and I can give you mine later on.
Okay.
Well,
That sounds good.
thanks everyone for joining for our lab meeting this month. We appreciate all of you coming on and listening and giving such great feedback. I know Annabeth really appreciates it. I know I would if I was giving a presentation at a large conference and got this type of feedback that the group was able to give. Please look out, be on the lookout from Lilia once we figured out when the next lab meeting will be. We'll probably do one as a combined between November and December, just given the holidays and everything. And if you are interested in volunteering to do any type of research didactic for this academic year, please contact Lilia too. I know she's been soliciting people to help with those. Awesome. Well, great, everyone. Thank you so much for joining, and we'll see you soon.
Thank you.
Bye.
Can you just tell me a little bit more about